Hello and very heartily welcome to this session of the Ziemer Symposium in Amsterdam. My name is Alireza Mirshahi of Bonn, Germany, and I have the pleasure to introduce you to this meeting. Actually, the real chair of this meeting is Professor Jod Mehta of Singapore, who is experiencing some problems with the internet connectivity, so it was my privilege to welcome you and wish you a nice meeting. We are not talking just about femtosecond laser. We are just talking about a fascinating technology that can be used in various different ways in the corneal, in refractive corneal surgery, in therapeutic corneal surgery, and in cataract surgery. So the organizers have provided a large variety of talks, and we start with Professor Jod Mehta's talk, which has been taken in a video, so please start the video. In the meanwhile, if you have questions, please do not hesitate to send them to me. I'll try to give it to the audience. I try to give it to the panelists and to answer to them. And last but not least, I'm happy to introduce my co-chair, Dr. Theo Seiler of Düsseldorf and of Zurich. So I think once you're ready, we are ready to start. Please go on with the video of Professor Jod Mehta.
So good morning, everyone. I'd like to thank the organizing committee for this kind invitation to talk at this symposium. I'm going to be talking about clear and what is the clear difference. These are my financial disclosures. So clear is an acronym for corneal lenticular extraction for advanced refractive correction. It's a lenticular extraction procedure developed by Ziemer, and it allows the creation of an intrastromal refractive corneal lenticle that can be extracted through a small incision to correct myopia and myopic astigmatism. SMILE is an acronym for small incision lenticular extraction, a lenticle extraction procedure developed by Carl Zeiss. It allows the creation of intrastromal refractive corneal lenticle that can be extracted through a small incision to correct myopia and myopia astigmatism. Now, you may think that these are actually quite similar procedures, and there is an old Thai saying is that things are same, but they can also basically be different. And the analogy can be extended to this picture over here of zebras, where they're all the same animals, but clearly there is something that's different with one of the zebras compared to the other one. So we have to compare and contrast on what we think that will be different between the two procedures themselves. So the first thing is we expect some of the visual acuity results to at least be as good as they are with SMILE as we see with CLEAR. And we know that the visual acuity results when you compare SMILE to LASIK have been shown from several studies. This is one meta-analysis that showed in 27 studies, there was no significant difference between SMILE and femtosecond LASIK with respect to safety, efficacy, and final spherical equivalence and vertical coma. And there was less aberration in the SMILE eyes compared to what we saw in the LASIK eyes. Likewise, we know from wound healing studies in animals that undergo lenticular extraction, there is less inflammation and less wound healing reaction as you increase the degree of myopia in the relax eyes and the lenticular extraction eyes compared to what we see in the LASIK eyes. We also know that the way the lenticle is extracted from the eye is also important, and the more difficulty the lenticular extraction can be, the greater amount of inflammation. And this can be in part related to surgical experience performing the procedure, where a more novice surgeon is going to induce more inflammation than a more basically experienced surgeon. And we know energy is also important. The lower the energy, the better the visual acuity rehabilitation at day one, all the way up to 1 month with respect to the visual acuity following lenticular extraction. The other thing we have to bear in mind is the fixation. We know in basically excimer-based treatments, patients have to look at an eye tracker in order to fixate. But with lenticule-based treatments, it's down to the docking of the laser when we're using current SMILE technology. Because if the docking is not correct, we have to then alter the position of the cone on the surface of the eye when we're actually doing the docking procedure. And we know from studies, including one of our studies, that the effective angle kappa can have effect on your visual acuity outcome. And the more you basically get decentered away from fixation, the more induction of vertical coma there is going to be in that individual eye as well. And this can be compensated for a little bit by increasing the optical zone size, but it's obviously limited by the amount of refractive correction that is going to be undergone. So what has first generation lenticular extraction shown us? Well, the refractive results are equivalent compared to LASIK, but the caveat is there is some certain variation. The results are superior with respect to ocular surface disease and dry eye disease postoperatively, and of course this is related to the small incision. The wound healing inflammation is superior to what we see with LASIK, especially for moderate to high degrees of myopia. You need to optimize the energy settings. The lower the energy settings, the better it seems to be. And it requires some nomogram adjustment when you're doing your programming. You cannot just take the manifest fraction. You do need to put the adjustment. Centration is very important to reduce the effect of reduction of vertical coma, and surgical experience can have an effect with respect to removing the lenticule. So it can try ways in which we can reduce the learning curve can help reduce this in the future as well. But we do know that the long-term stability of lenticular extraction is superior to what we see in LASIK. So when we think about second generation lenticular fixtures, what do we want? Well, we want a basically smaller footprint of the laser. Ideally, it'd be important to have a multifunctional laser. Because the suction with the Visumax system is actually quite low, there is always a risk of basically suction loss. So if either the laser has to be faster, or we have to basically try to reduce suction loss by increasing the pressure of the suction itself. Fixation is a real issue because you have to use the patient to help you with the fixation, and likewise cyclotorsion control. And when I'm doing currently SMART procedures, I have to rotate the interface cone to get the fixation, to get the cyclotorsion controlled. And this has to be done manually after you do the suction itself. And that also increases the risk of then getting suction loss, because the suction loss is quite low. Lower energy is better than higher energy. And of course, ideally, it would be nice to reduce the learning curve for surgeons so they can actually identify the lenticular edge when they're doing basically lenticular extraction. And in future, we hope you can link the laser lenticular extraction to a topography guided unit. So let's see what the differences are now with the clear procedure. Well, we know obviously clear is done by the Z8. It is a smaller footprint, and of course it's transportable from different OTs, so you can use it for your FemtoCataract machines, and then you can bring it down to the refractive suite to then do basically clear or LASIK as well. And we know it's multifunctional, so you can use many surgical procedures with this one laser. We know it runs on the same low energy concept that we've talked about many times before, running in the nanojoule range, and the suction on the surface is the same as it is for a patient undergoing a LASIK procedure. So the risk of suction loss is low, and the lenticule creation itself is only about 30 seconds with this laser system. If you want to learn more technical specifications, this is a paper that we published recently, where you can see comparisons over here with the clear procedure, with the SMILE, showing you some of the differences and some of the similarities with the procedures, how the lenticule is basically created. And you can see over here the energy pulse of the laser and the speed of the laser, the dioptric correction that is possible with the clear procedure compared to what we can see with the Visumax on the right-hand side as well. So how can we basically reduce the learning curve? Well, of course, one of the ways of reducing the learning curve is by basically having two incisions. And these incisions are not just there to help you get the lenticular extraction out. They're actually secondary to having guiding tunnels to actually guide you into the correct lenticular plane. One of the most common complications when people are starting off doing lenticular extraction is that often they will go into the wrong plane to actually remove the lenticule to start with the procedure. And using these guiding tunnels, what it can do is it can guide you to the anterior plane, like you can see over here in the pink diagram, incision on the right-hand side, and the posterior plane, as you can see, the orange incision on this side. This can help surgeons ensure they're in the right plane, which can make the removal of the lenticule a lot easier. The other thing I find very useful is the ability to actually move the eye with respect to cyclotorsion and rotate the eye after the suction is basically applied. So here you can see an example of one of my patients. We apply the suction. The sensor on the machine will automatically pick up the area where the marking has been done on the corneal surface. So that will help us with the cyclotorsion control. So you see the angulation of the cyclotorsion will actually come out very close to actually where the marks are. And the handles will basically appear. Then I can rotate it down. I'm telling the technician to move it now. And you can see the area where we're going to rotate. That looks pretty good on the rotation. and then we'll move it across a little bit to help us with the fixation. So not only can we compensate for sacral torsion very easily on the screen when the suction is already applied, but also we can actually get the fixation altered as well. So we know exactly where the lenticule is actually being created as well. And the flashing lights show us that we're in the basic meniscal range, and then you have a picture of where my incision is going to basically be created on the right-hand side. So in summary, first generation lenticular extraction has shown us to be equivalent with respect to LASIK, with respect to safety, efficacy, and predictability. You do need to optimize your nomogram. Centration is very important and can be quite difficult, and that is what leads to surgeon variability. Lenticular extraction is best for patients who could have had LASIK, i.e. have normal topography, but especially in patients with moderate to high degrees of myopia, anyone doing sports, certain occupations, and those are prolonged risk of dry post-op. Second generation lenticular extraction, like I've shown you with Clear, offers a chance to improve on what we have learned from the first generation systems by the ability to improve fixation, cyclic torsion control, be able to reduce the learning curve, and of course, it's provided to you by a low energy laser system. Thank you for your attention.
So I hear the connectivity is now available and Professor Mehta is with us. Professor Mehta?
Hi, Ali. Hi. Good afternoon. Good morning. Hi. Sorry for the issues with the computer. So I'm glad the symposium started well. So it's my great pleasure to co-chair this session with Professor Mirshahi, and I would be like to invite the next speaker, who's going to be Theo Seiler, talking about his experience with Clear. Thank you, Theo.
Thank you very much, Jod, for the introduction. I'm just continuing where you stopped on Clear, corneal lenticular extraction for advanced refractive correction, whether it's a new reason to smile or not. Here my financial disclosure. And before we talk about the results, I would like to run through one patient, how the planning of the procedure works, and afterwards coming to the results. So in the beginning, the first screen that you have is you need to, of course, select the correction of the patient, and therefore the curvature of the cornea is relevant, the asphericity is relevant, the pachymetry, and then, of course, the correction, the target refraction, and then the adjustment, which depends on the cap thickness and other parameters. The second variable that you have to decide is where to center on, whether you want to make a pupil-centered or whether you want to determine it manually. However, you need to mark this then afterwards in advance. You need to define the optical zone, the cap thickness. I started with 130, but of course there are also some people that go down to 110. That is your decision. However, you need to be aware that the nomogram changes. The last thing is the laser power. You can define the laser power for the anterior plane of the lenticular dissection as well as for the posterior plane. Jod already spoke about the incisions. Here you have one incision that ends anterior, one incision that ends posterior. You can decide whether you want to go with both, only one. And of course, you can also decide where the incision is, the width, the guiding tunnel, and the entrance angle in respect to the surface of the cornea. If we have now the geometry of those incisions, we'll see that one incision, the anterior incision, ends exactly in the anterior plane to facilitate the lenticule preparation, whereas the other incision is ending in the posterior plane. So even for newbies or for rookies in lenticular surgery, this helps to facilitate and flatten the learning curve, or steepen the learning curve. One good thing with the Z8 is that you always have an immediate OCT. So if you're not sure whether you have a 100% applanated cornea, you can do the OCT and see whether the applanation has happened. The next thing is a video how to distinguish whether you are anterior or posterior to the lenticule. I'm using in this video only one incision and the other one only as a backup incision in case I get lost. However, this has happened in the first two patients and afterwards not again. So I started now. You'll see the incision. I go into incision. Then I turn the hook. I'll see that I'm anterior to the lenticule because there's no reflex of the margin of the lenticule. And then I can just open it up and get an entrance for the dissection later on. However, another thing before we go to the surgery itself is the decentration or centration. Jod mentioned this already, that since Ziemer is using an applanating interface and not a curved interface, we can do a recentration of the lenticule in case of a not perfectly centered suction of the eye. Then the dissection itself, it works that we'll start in the posterior plane and afterwards go to the anterior plane. That's clear. And then the next step, I'll show you a video how this, I speed it up a little bit, get rid of the cavitation gas so the patient can fixate again. I'll open up the lenticule here exactly in the same way. As soon as this is done, I prepare the posterior plane. I'll go in with the dissector. Now preparing the anterior plane. You see that the dissection goes pretty smooth, not a lot of bridges. In the next step, I'll go into the posterior plane. You'll see when I apologize for the bad quality of that video. However, you see that the margin of the lenticule is anterior to the dissector. So this also is another benefit of this nice margin of the lenticule. I prepare it. And in the end, I speed it up a little bit. You just take it out. Double check that the lenticule has been inroofed in total. What are the results for the patient? For that specific patient, we had on day 1 results of 20/30 up to 20/25. This is more or less representative. However, we also had some patients that only had a visual acuity of 20/50 on day 1, but also 20/20. So you have a wide variation, which is, if you have a look at the FDA study from SMILE, which is pretty similar. On day 7, after 1 week, most of the patients achieved a visual acuity of almost 20/20, and after 1 month, they pretty much everybody achieved a visual acuity of 20/20. What about optical zones? You do see here on the right side the preoperative axial curvature map. 1 month later, the postoperative curvature map. That was one patient from July. You'll see that difference map from the axial curvature and the nice homogeneous optical zone that we induced. You also see, if you do a corneal wavefront analysis, you'll see that we did not induce any higher order aberrations from the cornea itself, and also the astigmatism or that the wavefront gave us remained the same. Let's have a look at the anterior segment OCT, the cap thickness. I told you in the beginning that I'm using currently a 130 microns cap thickness, which was well achieved in those patients. And from the total aberrometry, when we measure that, for example, in this patient, you'll see that from the pre-op values, from the lower order aberrations, they were pretty much totally corrected. The higher order aberrations maintained equal. So we achieved kind of an wavefront optimized treatment with this clear technique. Let me conclude. The first impressions of clear, it might be a new reason to smile. The advantages of clear versus smile are clear the incisions, which are superior. We do have a proper centration. And another good point is that the vacuum loss, since we have the same interface, patient interface, as with the LASIK or the general Z8 patient interface, which is flexible, we barely have no suction loss in those patients. When can we expect the first refractive results for clear? At the end of this year from our prospective study in Zurich. What are the next optimization steps for clear? And this is clearly the cyclotorsion control that is currently has to be done manually, but it was promised to provide it within the very near future. And what else can I tell you about the device? We'll hear afterwards a lot of other applications of the Z8. It's an all-rounder. It is a mobile device, and it can be from PK, DULC, femtosecond laser-assisted cataract surgery, flaps, intracorneal ring segments. It's really an all-rounder that you can use for many different kind of surgeries. From my side, that's it. If you have any questions, I'm not sure whether we do them right now or afterwards in total. Jod? Afterwards in total? Okay, so let's discuss them afterwards. Thank you very much for your attention.
Thank you very much, Theo. That's really interesting talk. I'm sure there'll be lots of questions on your initial experience as well. So we're going to shift gears a little bit, but we're going to maintain on the same theme of lenticular extraction. It's my great pleasure to invite my friend Rajesh Fogla, who's just come out of the OR, and he's going to be talking about stromal augmentation for keratoconus. Thank you, Rajesh.
Hello, everyone. I shall be talking about femtosecond laser-assisted stromal augmentation for keratoconus. I have no financial interest to disclose. Keratoconus is a non-inflammatory disorder characterized by corneal thinning and forward protrusion. The common options for visual improvement include contact lenses, intracorneal ring segment, and various corneal replacement surgeries. Collagen cross-linking effectively strengthens stromal collagen, which helps arrest or slow down the progression of keratoconus. Mid-stromal transplantation of Bowman's layer has also shown to be effective in arresting the progression of keratoconus and inducing some flattening. Femtosecond assisted intrastromal lenticular implantation with accelerated cross-linking has also been shown to be effective. In our study, we basically look at the outcomes of intrastromal implantation of cross-link lenticule in eyes with moderate keratoconus. We had 12 eyes of 11 patients with a mean age of 24.9 years. Regarding the donor lenticule preparation, the donor cornea was mounted on the artificial chamber, followed by alcohol-assisted removal of the corneal epithelium. The Ziemer Z6 femtosecond laser was used to prepare a 8 millimeter diameter lenticule of 100 microns thickness with 150 degrees edges. This layer also included the Bowman's layer. The donor lenticule was soaked in riboflavin 0.1% for 20 minutes, following which UVA exposure was performed 9 milliwatt per centimeter square for 10 minutes. In the patient's eye under topical anesthesia, the femtosecond laser was used to create a 9 millimeter diameter pocket at 200 microns depth. It had a nasal 2 millimeter opening and a temporal 5 millimeter opening. The donor lenticule was implanted using a microforceps and then unfolded and positioned. At the end, a bandage contact lens was placed along with topical antibiotics. Post-operatively, the patients received topical antibiotic for a week, topical prednisolone acetate for about next 6 weeks in tapering doses, along with topical lubricating eye drops. This is one of the case at 1 month follow-up showing the centrally placed intrastromal lenticule. That's the anterior segment OCT showing the lenticule at 200 microns depth, measuring 100 microns in thickness. This is the corneal tomography showing the pre and post lenticule maps. You can see the difference map. There is a thickness, there is a central flattening of about 4 to 4.5 diopters. And on the anterior segment OCT, the lenticule has increased the corneal thickness by about 100 microns. There's another case, pre and post lenticule. The cone has become more central following the implantation. And that's the difference map, again showing some amount of central flattening and superior steepening. Again, the difference map showing an increase in the thickness by about 104 microns. If we look at the high order aberrations, we find that both the total high order aberration and the coma show a reduction post-lenticule implantation. That's the overall clinical details. It's a busy slide, but if we look at the results, pre-op and post-lenticule, there is a slight improvement in the best spectacle corrected visual acuity by 1 line. The pachymetry definitely shows a statistically significant increase in the corneal thickness, and there's a slight reduction in the corneal aberrations. Now, basically what this study showed us that the donor lenticule can be easily prepared using the femtosecond laser. Corneal cross-linking possibly strengthens the collagen and reduces the amount of keratocytes, thereby reducing the risk of stromal rejection. The pocket can be created in eyes with keratoconus without any complications. The intrastromal implantation increases the corneal thickness, normalizes the central corneal keratometry without any negative impact on the visual acuity. The corneal clarity is maintained during the follow-up without any evidence of stromal rejection or progression of keratoconus. What about the role of topography-guided photorefractive keratectomy? We did perform topo-guided PRK in some of the cases. This is one patient, this is pre-operative, and best corrected visual acuity was 20/40, underwent lenticule implantation, following which you can see there is an increase in the corneal thickness, normalization of the central keratometry. The best corrected visual acuity did improve by 1 line, and that's the topography-guided PRK map. The planning, and this was also combined with accelerated cross-linking for 9 milliwatts for 10 minutes. And that's the post-operative topography. You can see that there's a significant reduction in the corneal cylinder, and the best corrected visual acuity in this eye improved to 20/20, and I had a follow-up of about 18 months. This is the post lenticule and the post topography guided PRK maps. You can see that the keratoconus in the last map almost looks like a regular astigmatism. Looking at the higher order aberrations, you can see that both the total aberrations and the coma show a slight reduction after the lenticule implantation, but there is a significant reduction after the topography guided laser ablation and the corneal cross-linking. This is again one of the patient's 5-year follow-up photographs. You can see that the cornea looks absolutely clear, and the visual acuity has been maintained at 20/20. So this is the pre and post lenticule. You can see that there is a significant amount of central flattening, and that's the topography guided PRK that was planned for this patient, along with the accelerated cross-linking. This is the map in 2016, and this is the follow-up in 2021. And if you look at the keratometry values, they have remained fairly stable without any progression of keratoconus. And the visual acuity also has been maintained at 20/20. And you can see that the higher order aberrations also are quite low, both the total aberrations and the coma. That's the difference map, pre-lenticule and the 5-year follow-up. And you can see that there is quite a significant amount of central flattening in this case. That's the overall clinical details. If we look at pre and post lenticule, the best spectacle corrected visual acuity, there is some improvement, but not statistically significant difference. But if you look at the post topography guided PRK, you find that the best spectacle corrected visual acuity along with the uncorrected visual acuity both show significant improvement. And if you look at the steep K, that also shows a reduction compared to the pre and post lenticule. And if you look at the higher order aberrations, you find that both the total and the coma are significantly lower following the topography guided PRK and the accelerated cross-linking. That's the overall summary. You can see that both the unaided and best spectacle corrected visual acuity has improved following the topography guided PRK and the cross-linking. The higher order aberrations and the coma have also shown a significant reduction. So basically, the femtosecond laser-assisted implantation of the cross-linked donor lenticule containing the Bowman's layer can be safely performed under topical anesthesia. We did not see any intraoperative or postoperative complication. There is a satisfactory increase in the corneal thickness and a stable topography, which allows topography-guided PRK to be performed, and following which you see improvement in both the unaided and the best spectacle corrected visual acuity and the stable parameters at last follow-up without any evidence of progression. So in conclusion, cross-linked lenticule insertion followed by customized keratoablation procedure seems to improve vision, stabilize progression of keratoconus, progression in eyes with moderate keratoconus without any adverse side effect. However, long-term follow-up is necessary to ensure stability in a larger cohort of cases. Thank you. Thank you for a patient hearing.
Great. Thank you very much, Rajesh. Okay. So Professor Seiler is unable to make it to the meeting today in Amsterdam, but Theo is going to give his talk, and he's going to be talking about refractive surgery at the hyperopic edge. Thank you, Theo.
So the topic is corneal hyperopia correction. It's pretty similar to the talk of Professor Fogla. However, the indication is a completely different one. First of all, we need to reconsider the success rate of myopic correction using wavefront guided, respectively wavefront optimized LASIK, and we'll see that in the majority of the cases, in more than 94% of the cases, we achieve a refractive success of less than half a diopter from the target versus achieved correction. Even if we see this after wavefront optimized, we are still in the range of up to 90% of success rate. How does it look with hyperopia correction? And in hyperopia, this is a completely different story. We'll see that this study showed in 413 eyes with the hyperopia correction that we only achieve the success rate in roughly 75% of the cases, which is a dimension less precise than the Excimer correction for myopic corrections. Why is this so? And the reason is the first thing that if we do that donut-shaped ablation in the periphery, we sometimes induce a very strong healing response, which is seen here, where you've done the ablation and you'll see an intrastromal healing response. The other thing is also that in hyperopic corrections, as all of you know, you cannot target always on the cycloplegic refraction, and there are many reasons why this precision of the procedure is just not as good as with myopic LASIK. Another problem that you're facing if you're doing a hyperopic LASIK and the regression is this here. You have the preoperative keratometry map. You'll see that this is a slightly hyperopic patient. We were targeting, or my father was targeting, for a monovision in this case. And up 1 year post-op, you'll see that nice central steepening. Also from the refraction, you do have a nice refraction of minus 1.25 in the spherical equivalent. However, 2 years after the surgery, you see that shrinking of the optical zone. And in addition, you see that development of that healing astigmatism, which is due to the constant remodeling of the epithelium and the constant lid irritation that is constantly working in order to induce a steepening in this meridian and therefore inducing an astigmatism with the rule. And from the refraction point of view, you also see this, that this patient, first of all, lost the myopia, but gained half a diopter of astigmatism, which cannot be the goal in such a hyperopic treatment. Here, that's a 16-year follow-up of hyperopic LASIK. You see that in the first years, there's a corneal regression. Afterwards, there's the internal process, what also contributes to that regression of up to 2 diopters after 16 years on average. So we are now talking always about removal of tissue in order to steepen the lens. However, there can also be a tissue inlay in order to steepen the cornea. And this is what you see here. That's an early OCT from a patient that my father treated in 2004, where he implanted a lenticule. You'll see here the margins of that lenticule at that time, which was not performed by the femtosecond laser. And you'll see that this can also induce a central steepening. And now I'm coming to the patient that he actually wanted to show. That was a 35-year-old man, contact lens intolerant, hyperopic of +5 diopters. And what can we offer to that patient? He had an anterior chamber depth of 2.2 millimeters, so ICL or artisan is not possible in this patient. What can we offer? And there we can ask the Z8, how can he help us with that? And we've seen this video, a similar video also from Dr. Fogla. However, this is now with the Z8. I'm removing the epithelium. I'm just jumping a little bit, making marks for the orientation. Then we are cutting a lenticule. Before it was a plano-parallel cylinder. Now we're cutting a lenticule using the clear program. You'll see here the typical trajectory of the laser. And then I'll just speed this a little bit up. I'm opening up the edges. And the next step, I'm preparing the posterior side. And again, the same as before, we are also using Bauman's layer on top. We did not remove this. We are just performing the posterior cut of the lenticule. In the next video, I'll show you the implantation of this of this lenticule. Again, we're doing a 10 millimeter wide flap in order in order to have the possibility to center the lenticule perfectly onto the visual axis, which we defined with the Varion system in advance. You'll see we'll unfold the lenticule, place it. Then in the next step, I'll just double check that I'm from the orientation right. I'll see from the reflex that Bauman's layer is up. This also facilitates afterwards the potential relift, since there's a clear membrane, and then I'll just reorientate it, reattach the flap, speed it up a little bit, reorientate the flap, and then afterwards it's just the treatment just like a regular LASIK. So, what are the results from the actual curvature? You see the preoperative map. 2 days afterwards, the postoperative map. You see that substantial steepening within the optical zone. However, you see that there still was a slight decentration of the lenticule. So from the visual acuity, the patient was not yet satisfied. And here the difference map, you'll see that nice steepening with a much wider optical zone compared to the regular standard hyperopic LASIK treatment. And afterwards, like 1 month afterwards, we've done a hyperopic wavefront guided treatment and a topography guided treatment in order to extend the optical zone and regularize the cornea. You see this here 26 days later, and the patient, after all, gained an uncorrected visual acuity from 0.3 in the beginning to now 0.9 or almost 20/20, 2 months after the surgery already. And here you also see that difference map, and that's also a nice application where the Z8, including the clear module, can be very helpful for a hyperopic treatment. Thank you very much.
Thank you for giving us this talk. We move on from fascinating new possibilities to already known procedures in cataract surgery, and the next talk is given by Dr. Stefanie Schmickler of Ahaus, Germany, reporting on 2,000 procedures conquering FemtoCataract in your daily practice. Dr. Schmickler.
Hello, I'm Stefanie Schmickler from Ahaus in Germany, and my topic will be 2,000 cases with FemtoCataract and how to start with it. First, it's extremely important that you convince and educate your employees on the advantages of FemtoCataract surgery. And of course, you have to convince and educate your colleagues in your clinic or outside of your clinic. And of course, you have to be able to explain why FemtoCataract costs more. It's more expensive than phaco, and you have to be able to explain it. Why femtolaser? Femtolaser offers a constant capsulotomy. It's ideal for premium IOLs. You have constant cuts, you have less phaco energy, and it's more safe as the eye is fixated due to suction ring during laser procedure, at least with our Ziemer Z8 handpiece. And therefore, you have better results. You have less trauma for the eye, clear corneas on the first postoperative day. Overall, the femtolaser limits the surgeon's error rate. How do we proceed with the femtolaser and the new patients in our daily routine? Step 1 is that the premium lenses advisor or the refractive manager explains the benefit of the femtolaser technique and the benefit of premium IOLs to the patient during the pre-op cataract exam. At the end of the pre-op cataract exam, the doctor, for example me, talks again shortly to the patient. The patient already knows a lot on femto laser. He's well informed due to our refractive manager. And therefore, it's mostly not such a long talk anymore to sign the informed consent and the financial agreement for the costs for the femto laser. What are the pros for the FemtoCataract procedure? It's high precision, which cannot be achieved by the human hand. And this is extremely important if you tell it to the patient. And it's the circular capsulotomy, which leads to a well-centered IOL, and therefore which leads to high stable refractive results. I only offer clear lens extraction with a femto laser. In case of posterior capsular rupture, the IOL can be fixated with a buttonhole technique. And overall, you have less ultrasound, which saves corneal endothelium. Which FemtoCataract laser? I have the Femto LDU Z8 after having worked with a different model for over 3 years before. Why do I like or prefer the Femto Z8? It's the different possibilities, opportunities which are offered by this femto laser. For the FemtoCataract, I have the capsulotomy, the fragmentation, the corneal incisions, which are fantastic, and the arcuate incisions. For the cornea, I have the LASIK, which can be done OCT guided. This is my favorite. We have intrastromal pockets. We can intracorneal rings do. We have lamellar keratoplasty. We have the dark with the tunnel for big bubble technique. We have the penetrating keratoplasty with applanating interface or with liquid interface as an alternative. And we have clear, which is a different topic in this session. The advantage of the Z8 in my daily routine is it's a mobile space-saving laser. We have 4 operation theaters, and the laser sometimes changes within the different theaters. The laser only runs when needed. And we have the intraoperative OCT. The laser does not require special room climate in contrast to other femto lasers. And we have the fixation of the eye during laser treatment. And overall, we have a good customer service, customer-orientated company because of family-owned. And the patient asked for femto laser cataract surgery. In my hands, I use the Z8 for extraordinary cases. For example, hard nucleus, cornea gutata, shallow anterior chamber, extreme hyperopes. And therefore, I consider the FemtoCataract surgery as superior to the conventional phacoemulsification. And as a modern cataract surgeon nowadays, you have to offer FemtoCataract surgery. The patient demands for it. Here are some examples from our eye surgery center. You see the Femto Z8 laser in the corner in the back of this operation theater. Then if we start, we roll it to the surgery bed. Then suction is started under the microscope. Gently lift fixation ring in order to check the vacuum. And then I remove the microscope for the femto laser treatment. And if it's all done, the femto laser rolls back into the corner of our operation theater. Here you see our FemtoCataract procedures. I started FemtoCataract laser surgery in 2013. We had only a few cases, not so many. And then we switched to the Z8, which convinced us much more for this technique. And you see that we have climbing numbers all over the years. Even in 2020, when COVID started, we had more surgeries than before with the FemtoCataract laser. Our experience with the Ziemer company is highly motivated team with excellent service. FemtoCataract can also be done with narrow lid margin. And it can also be done if the conjunctiva is swollen, and that does not lead to pupil construction due to the low energy. It's ideal for complicated eyes, for example, cornea guttata. It's nice Swiss design, and we have an increase of privately paid cataracts. Thanks to the Ziemer company and for their excellent support.
Great. Thank you, Stefanie, for that great talk. So it's my great pleasure now to invite my co-moderator, Professor Mirshahi, to talk about intraoperative complications of laser cataract surgery in a real-world setting. Thank you.
Yes, thank you for introducing me. When it comes to cataract surgery, I think the most important thing you're gaining with a femtosecond laser is predictability. Of course, most of us can do capsulorhexis, and most of our capsulorhexis are great, but are all of them great? I have to say, no. Nobody can really say you have a capsulorhexis size of 5.2 millimeters in 100% of the cases, and this is what you gain when you move on to the femtosecond surgery in cataract. And what is important about the technology, let me say a couple of sentences before I come to my talk, is the movability and the versatility. Whenever you get a new technology, you do not need to construct a new operation theater to offer it to the patient. You just can offer it to the patient using the same versatile system. And using such a versatile systems, we still need to talk about the safety, and this is what my talk is about. I report on intraoperative complications of laser-assisted cataract surgery in a real-world setting. So the purpose was to report the rate of intraoperative complications. This is a retrospective study using a low-energy femtosecond laser. And what does it mean, high-volume real-world setting? It means that it's not coming from a prospective setting. It comes from real-world. It's a private hospital. We're doing more than 6,000 cases in a year, and both surgeons who have done the femto laser surgeries are doing more than 1,000 cases a year. So it's a high-volume real-world setting. We consecutively looked at our case series, and we looked at our surgeries done between 2015 and 2019, and they were done in either hands of 2 experienced surgeons. And we excluded the first 20 cases of the surgery because we know there is a learning curve, and I will be happy to report even on the complications in the first 20 cases. But as we started the study, we said, okay, we need to exclude the first 20 cases because of the learning curve. And we reviewed our surgery reports. So what was the surgical technique? We used the Ziemer ZH. We did the lens fragmentation with 80% laser energy in an 8-piece pie pattern. We did a capsulotomy of 5.2 millimeters with 100% laser energy. We adjusted the capsulotomy size and the position according to intraoperative OCT images. Afterwards, we moved to the phacoemulsification. We did the incisions manually, 1 main incision, 2 paracentesis, and we used the Alcon Centurion system for phacoemulsification, bimanual IA and IOL implantation. What was the study cohort? 1,806 eyes of 1,000 patients. The youngest was 21 and the oldest lady was 99. So you're looking for the first 100-year-old patient to be operated on. And it was half right and left eyes. The surgery was done in peribulbar anesthesia and sedation, except in cases who were on systemic anticoagulation with warfarin, fenprocomol, and or similar. So what are the results? We just have 5 single cases of capsular tears, which is equivalent to a rate of 0.28% with a confidence interval of 0.04 to 0.52%. We had 3 cases of anterior capsular tears, and the surgery could be moved on with regular IOL implantation in the back. This is equivalent to 1.0 to 0.17%. We had 2 cases of posterior capsular tears, one with anterior vitrectomy, and in both cases the surgery could be completed with IOL implantation in the sulcus. This is equivalent to a rate of 0.111. We had no cases of vacuum loss, and we had no other intraoperative complications to report. Let's look at those 5 complication cases. 3 of them had hard nuclei, means lox 3 of 4 or more. 2 showed with positive posterior pressure, and all of them had some challenging conditions like floppy iris, shallow anterior chamber, posterior subcapsular cataract, and primary capsular fibrosis. So the question arises, so having 0.2% of complications, is it high or is it low? So we looked into the literature and we tried to differentiate to distinguish between the high energy and low energy reports. And if you see in the high energy, we have complication rates around 1%, going up, if you're looking at the publication of Popovic, of up to 5% capsular complications. So if if you're starting as a surgeon doing cataract surgery and you're expecting 5% capsular complications, I think every surgery would be challenging. And looking down to our series, if you're going down to 2.8%, it makes you feel more comfortable. And of course, first, we do not harm. Well, we need to take care that we are not only looking at different technologies, we are looking also at different surgeons. But when it comes to anterior capsular tears, I think most of the cases are related to the technology. And again, if you look in the high energy data available, we have between 1 and 1.77%, and looking at the low energy data, the safety goes down to 0 and 0.17. So it's around 5 to 10 times less likely you experience the anterior capsular tear, and it gives you a bit more of safety. So the take-home message, this is, to our knowledge, the first large study reporting on intraoperative complications. Why is nobody has reported it before us? Because they are so rare. And if it's rare, so the most surgeons, they do not see the necessity to report on it, but I do see the necessity because safety also counts. There were no complications except for a low number of capsular tears, and I believe so that the low energy concept seems to allow a stable capsulotomy. This is my conviction. Anterior and posterior capsular tears, in any case, did not result in a disadvantage for the patients. IOL could be implanted successfully in our cases. We do not have comparative data to conventional phaco emulsification, but we do have historical data to high energy devices, and I think the comparison, although it is not a head-to-head prospective study, is quite clear. You reduce the possibility of experiencing tears by factor 5 to 10. And of course, when you have so low numbers of complications, you need even larger study cohorts to have better data and better reliable data. Thank you for your kind attention.
Great, thank you, Professor Mirshahi, for that very interesting talk. So I think we have a few minutes. So I'd like to thank all the speakers for their excellent presentation. So I'm just going to ask a few questions. So we'll start with Theo. Theo, I just wanted to ask you on just your talk. Now, you mentioned about a bit of a learning curve, and also you mentioned how being a rookie surgeon at doing clear or lenticular extraction, you've been able to reduce it. So if there was one tip on somebody starting off doing lenticular extraction with doing clear, what would you tell them?
That's clearly the orientation in the beginning where you are. So I think that's one of the most important thing, that you always know where you are, whether you are anterior or posterior to the lenticule, and this is something where the two incision concept of Ziemer has definitely a big advantage.
Yeah, I agree. Okay, and just because you gave your dad's talk as well, Can I ask you on your on behalf of your dad? Can you comment on why he feels that doing a flap is better than doing a pocket?
To be honest, I think it was. No, I think that was because of the centration, because a 10 millimeter pocket, I think it's limited to 8 millimeters. Correct me if I'm wrong. I'm not sure about the dimensions, what is currently possible, but I think that was the reason why he was doing a flap and not a pocket. But
okay, great. Okay, we'll ask him next time, hopefully when I can see him and stuff, to really tease him on that. Okay, great, thank you there. Okay, so Rajesh, you showed some nice use also of lenticular extraction for keratoconus. What I was going to ask you is that if people, they saw the technique that you showed with the donor preparation and then the implantation, what is a good case for somebody who wants to try this stromal volume enhancement? What kind of keratoconus case would you advise them?
I think a moderate keratoconus with at least 320 to 350 microns of corneal thickness at the thinnest point. That will allow you to safely create a pocket at 200 micron depths with a 100 micron safety margin when you're using the femtosecond laser. And so basically the patients in my series were cases who were intolerant to contact lens wear, and they were looking at an alternative option before considering DALC.
Oh, yeah.
So this was a procedure where even if the outcome was not up to their expectation, it did not alter the prognosis of the DALC surgery in any way.
Yeah. Okay. But and as with respect to topography, central cones, inferior decentered cones, or what kind of cones?
These are fairly. Most of the cases in my series were slightly inferiorly displaced cones. And when we did the lenticule, we found that the cone moved centrally. So basically, it resulted in a better power distribution within the cornea. But off late, we have done a few cases where we have done laser ablation to the posterior aspect of the lenticule centrally to make the central lenticule thinner by about 70 to 80 microns. So you have the peripheral lenticule being thicker. And having implanted that, we have had a similar kind of outcome, what we see post-topo-guided PRK of a central flattening. So that reduces the need for, more tissue removal from
laser.
200 microns when subsequently you are doing a laser ablation.
Yeah. So there's a lot of discussion about what kind of shapes basically to put in, and some of the stuff that I'm doing with Mario in Chieti with Leonardo, we're basically using dumbbell shaped lenticules to basically put them inside the eye. And we had a paper showing that how to do the Ziemer laser treatment on the lenticules and stuff with hydration. But I think it's great that it's a minimally invasive procedure that could basically help out for these patients. Thanks, Rajesh. So, Stefanie, you gave a really interesting talk about your experience on cataract surgery. One of the things you mentioned about FemtoCataract was the fact that, and I agree completely with what you said about using premium IOLs and how it can basically help with that. Can you just give us an idea you showed an excellent, increase in use of FemtoCataract procedures. What kind of percentage of your cases are premium IOLs?
30%. 30% are nowadays premium IOLs, but not everybody takes the Femto laser. But of course, I think in my hands, I use the FemtoCataract laser in about 15 to 20% now.
Okay. And has that, and let's say over 5 years, what's been your rough percentage increase in your premium IOL usage, and why is that increased?
Because patients read about it, they read about in journals on the new technique, and they demand for it. I have patients coming away from 80 or 100 kilometers to ask for surgery with a laser and not with a phaco.
Phaco, yeah, okay, great, all right. And Professor Mirshahi, you gave a very nice real-world talk about using the laser cataract machine. What I was going to ask you was, you talked a lot about the capsulotomy results, and I think it's really valuable to show your series. You have a large series, and I hope you publish it, comparison to high-energy laser systems. And one of the things you mentioned about was anterior capsular tears. And of course, I think that's one of the strengths of the Ziemer system using low energy, that the capsules are much stronger than with a high energy system. And we showed that previously with human capsulotomies. Do you think that the advantages, I mean, will allow more different types of lenses to basically be used on because of the fact that the capsules are much stronger?
I beg your pardon. Can you repeat your question because it's quite loud in here in this room?
There are a lot of new lenses that are available now, like the Femtis lens, which is a clip-on lens to the anterior capsule, and there's some other new accommodative lenses that are available that requires a strong capsule to be created. But say specifically the Femtis, which clips in to get perfect centration onto the anterior capsule. Do you think this is one of the advantages of using the ZX for creating your capsulotomy?
I would say absolutely yes. When I started with the cataract surgery with the ZH, I was very, very careful with the anterior capsule. I expected tear every day. And now I started to stress it, to polish the anterior part of it. For example, in pseudo-exfoliative cases, I polished the anterior part of the anterior capsule. And then I started to polish the posterior part of anterior capsule just to say, okay, how far can you go before a tear occurs? And my personal feeling is it is as strong as a manual capsular axis. So it can be, of course, uses for new IOL technologies that are dependent on a perfect size and a perfect strength of the capsulotomy. I would say absolutely yes.
Yeah. I mean, I can tell you just anecdotally, I mean, regardless of all the wet lab stuff that we did, but I did a patient that had a Femtis lens, and actually the requirement of the lens is a 5mm Rexus, but for whatever reason we couldn't do that, so we could only do a 4.7mm Rexus because the pupil wasn't dilated enough. And actually it was the mother-in-law of the laser technician who was actually doing the lasering programming for me on that day. And so when he programmed it and I took the cataract out, put the lens in and I had to clip it to the anterior capsule, I was actually worried about how much stress I was going to put on the capsule. But actually it wasn't that difficult to clip in. I was surprised, I think he was surprised or happy at the time that it was actually to clip in. And I think that's a really advocates the fact that how strong the capsule is and stronger than we basically think that we get from other laser cataract machines as well.
I mean, sometimes you have tags. You might have tags. I'm not saying, but you need to release the tags at the beginning and do not expect a tear where you observe the tags. This is at least my experience.
Yeah, that's right. Yeah. Okay. So, Professor Mirshahi, any closing comments as co-chair of the session?
Well, my closing, I'm very happy you could join in because I was afraid I have to do it with me and my colleague Theo. I'm so happy you could join in. Thank you, Jod. Thank you. And thank you to the audience.
Can you believe it? They just announced today that we are actually free to travel to Amsterdam just from today. The Singapore have allowed us to come to Amsterdam. So, you know, if it was 1 day later, I could have flown out tonight for the symposium. But anyway, never mind. Hopefully next year we'll be able to meet at the next year's meeting. So I'd like to thank all the speakers for their excellent presentations and to keeping to time. I wish you all a happy meeting in ESCRS and look forward to meeting you next year or later on this year, hopefully at some other meetings, and hope you have a very good day. Thank you very much, everyone. Thank you.